Now, welcome back to another lecture. We'll be talking about HHS, hyperosmolar hyperglycemic states. Now, hyperosmolar hyperglycemic state is a complication that happens in patients who have type 2 diabetes, and it is characterized by hyperglycemia and hyperosmolarity. There is minimal or no ketoacidosis, and it's very common in the African American race and patients who are obese. There are also patients who are comorbid, have many comorbidities. The pathophysiology of how it develops: you have an insulin resistance, stress, and what happens is that because there's these stress hormones like cortisol, glucagon, these increase glucose in the blood, decrease its utilization, and that causes an osmotic diuresis. Because the kidneys try to get rid of this glucose, they get rid of the glucose and losing water and electrolytes. You have increased glucose, and glucose increases here. That draws the fluids from the intracellular compartment to the extracellular or intravascular compartment. And as this progresses, you can see that there is osmotic diuresis and release of the fluids and electrolytes in the urine. Then you have this condition where the overall fluid in the patient starts decreasing. Now, it's important to note at this point that our main treatment in patients with HHS is actually to treat the hyperosmolarity with fluids, and it's not to start insulin. And as you'll see, that these patients have glucose levels of about more than 600 milligrams per deciliter, sometimes reaching 1,000, 2,500. So these numbers can be very scary for a junior doctor, and you'll try to lower them as soon as possible. But this is actually wrong. And the reason for this is when the patient progresses in his condition, he will be volume depleted. And once you give insulin, what happens is that insulin draws in the glucose into the cells, and that causes the intravascular compartment to be completely depleted from fluid, and that can cause intravascular collapse and hypotension. So it's very risky to start with insulin. Never start with insulin in a patient with HHS. Give them fluids adequately at first, and examine the patient and see that the signs of dehydration have resolved. Then you start insulin. I will be talking about this more detailed later on. Now, this is the pathophysiology. You have to have a stressor that increases the counter-regulatory hormones. So we said these patients are comorbid. They have many conditions going on. They can have diabetes, hypertension, and the precipitant usually is something like a myocardial infarction, a UTI, a gastroenteritis, and pneumonia. Now, what happens is when the stress increases, counter-regulatory hormones increases, you've got insulin deficiency in this patient, right? And what happens is that because this causes decreased utilization of glucose, hyperglycemia, and production of new glucose from proteolysis and gluconeogenesis. So everything leading to hyperglycemia without the utilization. Now, this causes, of course, as we said, the osmotic diuresis, and therefore you lose the electrolytes and water. That causes a hypokalemia, hyponatremia, and hypophosphatemia. And therefore, you have a patient who's dehydrated and hyperosmolar. Now, the hyperosmolarity itself leads to a risk of thrombosis. And again, as we said, there is a risk of hypotension and shock. Now, lipolysis in DKA, there is lipolysis and there is production of ketones. But because these patients are not fully insulin deficient, like DKA, they have some insulin, and that can actually prevent and inhibit the production of ketones and lipolysis. So therefore, you will see that in the criteria that in HHS you have no ketones at all, or slight mild ketosis, while in DKA the main feature is actually large amounts of ketones. Now, the criteria for hyperosmolar hyperglycemic state compared to DKA, the glucose levels is usually more than 600, and the serum bicarbonate is more than 15. And the reason for this is that there is less ketones, less weak acids in the blood, more serum bicarbonate staying in the blood, whilst in DKA, because of the high ketones, there will be a decreasing serum bicarbonate. Again, the ketones are negative or small amount, mild, while in DKA you have positive ketones. The serum osmolality is very important. It's over 320 milliosmoles. Again, the anion gap in HHS is less than 12, while it's more than 12 milliequivalents per liter in DKA, and the pH is actually more than 7.3, which is actually going towards alkaline, while in DKA, because of the ketones and the weak acids being produced, it is less than 7.3. The severity of HHS include a serum osmolality of more than 350, and this is actually a very high osmolality, which could precipitate so many complications like thrombosis, cerebral edema, pulmonary edema, and we'll be talking about these later on. A sodium of more than 160 millimoles. Usually in patients who have hyperglycemia, if you have hyperglycemia, usually there is osmotic diuresis and increased fluids within the patient, and that actually lowers the sodium. So usually they have hyponatremia. However, as the condition starts progressing, more dehydration develops. Say, for example, it is a stroke patient or a patient with dementia. Worsening of his condition leads to dehydration, decreased water intake, and that means that the sodium starts increasing. So once the sodium increases, this means that this patient is very at a late stage of presentation, and this could mean worse outcomes. Now, a pH less than 7.1 is another one, and the reason for this is usually we said the pH is more than 7.3 in HHS, but being less than 7.1 could mean that there is, because the dehydration, there is a dehydration in these patients that can cause shock, and patients who reach this stage of shock means that they have probably elevated levels of lactate, and therefore that can cause the pH to go this much down. Now, of course, a Glasgow coma scale of less than 12 is also problematic, because the hyperosmolarity itself causes altered mental status and coma and stupor. So a decrease in the Glasgow coma scale means progression of symptoms and progression of the disease. Now, an SpO2 of less than 92 is also a marker of severity and bad prognosis. Tachycardia or bradycardia, decreased urine output, a creatinine of more than 200 micromoles, and a patient having an acute kidney injury, hypothermia, having macrovascular events like stroke, and other serious comorbidity are all markers of severity. Now, there may be conditions that could precipitate hyperosmolar hyperglycemic state. And as we said, infections are the most common, like pneumonias, urinary tract infections, myocardial infarctions. So you always look for the precipitating cause. Look for precipitant. If you can't find it, sometimes you'll miss it, but just make sure there is very likely to be a precipitant for this condition. Renal insufficiency as well, cerebrovascular events like strokes, mesenteric ischemia, and many more. Pulmonary embolism. So sometimes you have conditions where you treat the condition and the osmolality is not resolving. That could mean that the precipitating condition has not been treated yet. Some drugs also may predispose patients to develop HHS, especially antipsychotics, antidepressants. Antipsychotics like chlorpromazine cimetidine, which is an antihistamine, glucocorticoids, because that raises the levels of stress hormones and it raises the levels of glucose itself. Beta agonists, antipsychotics, as we said. Phenytoin, which is an anti-seizure medication, can also predispose to this condition. Immunosuppressive drugs, and many, many more. Now, why is there a minimal ketoacidosis? Why is it not like DKA? And the reason is because there is higher levels of insulin compared to DKA. And also, the hyperosmolarity itself inhibits lipolysis. Now, there are conditions where HHS is prone to produce ketosis, and these are called ketosis-prone type 2 diabetes mellitus. And in these conditions, you'll see that these patients usually have a lowering bicarb. And this is very important, and that's why you always keep monitoring a patient with HHS. You always send for ABG, because at any point, the HHS can actually develop into DKA, and then you have to start treating with DKA protocol rather than HHS. Now, usually we try to prevent this because we try to give insulin with mild ketosis, HHS with mild ketosis, or a beta hydroxybutyrate of more than 1 millimole. We try to introduce insulin to prevent the production of ketones and progression of the disease, because with HHS, our main goal is to treat the hyperosmolarity. So we don't want to go into DKA, where the treatment becomes more complicated, and now you have to treat the ketones, the glucose. That will make the things very more complex. Now, the symptoms of a patient with HHS, they are usually gradual over days or weeks. He'll probably feel very fatigued. Most of them are bedridden. They will present with, for example, confusion and vomiting, and this is because of the hyperosmolarity causing altered mental state and causing cerebral edema. They can even present with seizures, and risk factors include being an elderly or taking psychiatric medications like antidepressant and antipsychotics. On physical exam, you'll actually see that they have dry mucosa, poor skin turgor, and sunken eyes, signs of dehydration. They can have tachycardia and hypotension, and that means that there is shock, and you have to treat very quickly in these conditions. They can have also lethargy and coma, and you always want to check the heart rate, blood pressure, and JVP, and capillary refill once you start introducing fluids, because these can indicate whether the fluids are helping this patient or not. We always introduce a treatment and then we remonitor and see the response. What you would send this patient, you would send for CBC, a metabolic panel, you look for electrolytes like magnesium and phosphate, and you produce a urinalysis to see, for example, if there's any signs of urosepsis or a UTI that could have precipitated the condition. You also want to check the osmolality and calculate it. Lactate is to exclude any septic shock, for example, because a septic shock would increase the lactate levels. Beta hydroxybutyrate to see if there's any ketones, and perhaps, for example, the HHS might change into DKA. So then you have to change the protocol of treatment, and the more the condition worsens, the more likely he will convert. You also want to do cultures, cardiac markers like troponin, for example, if there's an ongoing myocardial infarction that precipitates the condition. You want to send for ABGs and VBG routinely. Thyroid tests, for example, hypothyroidism could mean that there's hyperglycemia and could precipitate the condition. A chest X-ray to look for pneumonia. An ECG can be done as well to look for myocardial infarctions. CT for looking for a stroke. And lumbar puncture, for example, looking for a subarachnoid hemorrhage. Now, a normal serum osmolality is between 275 and 295 milliosmoles per kg. As we said, HHS, it reaches above 320, and that's when altered mental status happens, cerebral edema happens, and coma and stupor happens. Now, once we introduce fluids, the rate at which we want to decrease, for example, the osmolality, should be between 3 to 8 milliosmoles per kg per hour. This is according to the reference Davidson Principles of Medicine. You can also calculate the potassium loss by using this formula. But usually with potassium, we give potassium and then we monitor and see how much the levels are reaching. So you need close monitoring, and you need to put the patient on cardiac monitoring. Now the reason, what happens in the beginning, you actually see that the potassium levels seem to be normal in a patient with HHS. And the reason for this is that you have a patient who's dehydrated, he has dehydration, slightly acidic, and then you have potassium right here, and so the body tries to compensate the protons by exchanging them with potassium. So the protons go inside the cell, the potassium goes out, and therefore once you measure the potassium, it seems that it's normal. But once after you introduce fluids, you will actually see that there is an hypokalemia, and then we start treatment. Again, the main goal of treatment is to improve tissue perfusion and treatment of hyperosmolality. So the main treatment is fluids. You want to correct the hypovolemia and the electrolyte abnormalities. Now it's important to note that correcting the electrolyte abnormalities may take 3 days, 2 to 3 days to actually correct. But as a junior doctor or in emergency department, for the first 6 to 12 hours or 24 hours, your main focus is actually to give them fluids and whatever deficit that has happened to the patient, you want to give them those fluids and correct them. And then after introduction of fluids, you start thinking about treating the hyperglycemia. And always an important note, don't introduce insulin without checking the levels of potassium, because insulin can further decrease the level of potassium, and that can cause you tachyarrhythmias or bradyarrhythmias and many things to the heart. So you always want to check the potassium levels before giving insulin. Again, you have to always do frequent monitoring. So once you start fluid resuscitation, you start with normal saline. This is 0.9% normal saline, and you usually give it at a rate of 1 liter per hour. Usually these patients, there is a way of calculating their fluid loss by using MedCalc. That's an app you can use, but usually they lose about 8 to 12 liters usage, which is about 25% of their body weight. Now your main goal is to actually give them in the first 6 hours 2 to 3 liters. Now this is according to Davidson, while Tintinalli gives you you can calculate it using, you shouldn't give more than 50 milliliters per kg according to their body weight within the first 4 hours. Later on, in the first 12 hours, you should be giving at least 3 to 6 liters. And this 12 hours covers the majority of the fluid loss that the patient has developed. Now, sometimes you actually change 0.9% normal saline to 0.45%. This isn't necessary to always happen, but once for example you start giving fluids within the first 12 hours and you see that the osmolality is not dropping, then you might want to consider starting hypotonic saline. If in some departments there isn't any hypotonic saline, so therefore you can use, for example, half saline with 5 dextrose or dextrose saline. Probably these patients are already on insulin, so you would recalibrate and change the infusion rate of insulin to account for the extra dextrose that you've added in their fluids. Now, to summarize the fluid therapy that you're going to be giving this patient, you give the fluids, you give 0.9% normal saline in the beginning, 1 liter per hour, and then you monitor the osmolality. Now, if the osmolality is decreasing by less than 3 milliosmoles per kg per hour, and you actually examine the patient's fluid status, you look at the capillary refill, the JVP, the mucosa, skin turgor, and you see that there is still signs of dehydration, negative fluid balance, then what you do is you increase the rate of infusion. Now, if it's decreasing at an appropriate rate, you continue at the same rate. If the decrease in osmolality is more than 8 milliosmoles per kg per hour, then you might want to decrease the rate of infusion, fluid infusion. And this is because too much fast decrease in osmolality can cause a complication called cerebral pontine myelinosis. And you don't want to go there. If you give fluids and you see that after you've given the 0.9% normal saline, you see that there is an increasing osmolality rather than the decreasing. If the patient still is dehydrated, you increase the rate of infusion of the fluid. If otherwise, that the patient, you've given them for example, 3 to 6 liters, and the osmolality is plateauing or it's not working anymore, then that's an indication for hypotonic saline. So hypotonic saline has a certain indication. When we're giving 0.9% normal saline and it's not the osmolality is increasing rather than decreasing, then you might want to start considering switching to a hypotonic saline. Now, why do we rely on osmolality and not look at the sodium? The problem is once you start introducing fluids, the glucose is reduced, and that's because when glucose decreases, less fluids are in the intravascular compartment. So once glucose decreases, the water decreases, and that causes increase in sodium. So once we give, initially when we start fluids, it is very likely that the sodium starts increasing, and this can be a warning sign for junior doctors, and they think that probably something is going on, but this is normal. As long as the osmolality is still decreasing, you calculate the osmolality and you see that, for example, it was 320. You're giving fluids, now it's going down to 300 milliosmoles. And you see that the normal sodium is increasing. You shouldn't be scared. This is normal. Now, in patients with fluid overload or volume overload, for example, patients with COVID, heart failure, or chronic kidney disease, they have different amounts of fluid that you'll be giving, and it is actually calculated by 0.25 milliliters per kg per hour. And if you look now, this table shows that how much fluid that you give at a certain glucose level, above 50 millimoles or below 50 millimoles is about 1,000 milligrams per deciliter. You see that, for example, for a 60 kg patient, you give about 125 milliliters per hour. Now, and usually in patients who don't have risk of volume overload, we give about 0.5 to 1 liter. That's per hour, and that's how much we started on 0.9% normal saline when we talked about fluid therapy. But in these patients, you actually give only 125 milliliters per hour, and this is because these patients you express more caution, and you don't want them going into a complication. So there is a different strategy of calculating the fluids for people with volume overload. Now, once you start therapy, you always want to monitor your patient, and you hourly send for glucose levels, sodium levels, potassium levels, and urea, and you calculate the osmolality every hour for the first 6 hours, and then later on, every 2 hours, once you see that the response is that there is a decrease in osmolality between 3 and 8 milliosmoles per kg per hour. You always have to make a chart for everything, the amount of fluids you're giving, the osmolality, and you always want to continuously monitor their pulse oximetry, and you want to continue monitoring their heart, because any changes in potassium can cause arrhythmias, so you want to monitor the heart. Now, you don't need to monitor corrected sodium. Usually we don't rely on corrected sodium, we rely only on osmolality, and measuring the measured sodium is enough. Now, the corrected sodium has a role once the patient, you're giving fluids and the osmolality is not changing, then you start thinking that there is probably another condition that's causing the elevated sodium levels, like syndrome of inappropriate antidiuretic hormone, or cirrhosis, nephrotic syndrome. So you have to look for another cause for the condition. Now, insulin therapy, you want to start insulin therapy or considering insulin therapy once you've resuscitated the patient and given the initial 3 to 6 liters of fluid in the first 12 hours. Now, you want to start earlier in a patient who's mildly ketotic, and we've already said why, because you don't want these patients from transferring from HHS to DKA, and that makes the management more complicated. If the patient has a ketonemia or a level of 3-hydroxybutyrate of more than 1 millimole, you want to start insulin. Now, usually the rate we start insulin is 0.1. It can also be sometimes 0.05. Davidson says actually you should start with 0.05 units per kg per hour. Tintinalli says 0.1. And you actually monitor the level of decrease in the glucose. Usually it should be between 50 and 75. Now, Davidson says between 80 and 100 milligrams per deciliter. Once the glucose level reaches less than 300 milligrams per deciliter, you start introducing 5% dextrose, half normal saline. This is to prevent hypoglycemia. And always, once before stopping insulin infusion, you always have to give a subcutaneous basal insulin, and this can be started like 2 to 4 hours before stopping the IV infusion of insulin. And then you of course calculate the daily insulin, and you can refer the patient to endocrinologist for recalibration of his drugs. As we said, when there is mixed DKA and HHS, you will see that there is more than 3 pluses on ABG or VBG. The levels of bicarbonate start decreasing, and you should always send for lactate to exclude something like a septic shock. In these patients, you treat as DKA and it's more difficult to manage, so we always consider giving insulin with mild ketosis to prevent this exaggeration of the condition. Now, hypokalemia, there's always a risk of hypokalemia, and usually before starting insulin, you have to measure the levels of potassium. We've already said this. So if the levels are less than 3.3, you have to give, with the fluids, potassium chloride. And usually the potassium chloride come in ampules of 20 milliequivalents. Now, you can give between 10 to 20 milliequivalents. If it's more than 20 milliequivalents per hour of KCl, you always have to have a central line. You can reach up to 40 milliequivalents. Magnesium can also be replaced. Usually it's given orally. We give oral magnesium rather than peripheral IV magnesium, because the peripheral IV magnesium we only use in, for example, in torsades or ventricular tachycardias. But in HHS, the hypomagnesemia is usually treated orally. You only treat phosphate when the level is below 1 milligram per deciliter. And sodium bicarb, usually as junior doctors you'll not be using it because it carries a lot of risks, and usually it's restricted for use in ICU. So don't think about using it. But it's usually used when the pH is less than 7 or 6.9 according to Tintinalli. This is the KCl ampule. You can actually see that it contains 20 milliequivalents of potassium chloride. So what you would do is you would give, for example, if you want to give 20 milliequivalents per hour, you dilute the 1 ampule in 500 milliliters of fluid, and then you give the 500 milliliters in the 1 hour time period. This slide summarizes the whole treatment of HHS. The main part of treatment is fluids. You want to give fluids to at a rate in the beginning of 1 liter per hour, 0.9% normal saline. You want to give about 6 liters in the first 12 hours. And whenever you give fluid, you always have to monitor the osmolality. And we've already said if the osmolality is dropping too fast, if it's dropping too slow, you have to change the rate. If it's not changing at all, and you've given all the fluids to treat the dehydration in the patient, and this patient is no more dehydrated but the osmolality is not changing, then you may consider starting, for example, half 0.45% normal saline. Now the insulin, you start at 0.05 or 0.1 units per kg per hour, and you also, again, once you start, you have to check the potassium levels before you start insulin, and you monitor the level of decrease in the glucose. Again, it has to be according to, for example, if it's Davidson, 80 to 100, so not less than 80, not more than 100, or in Tintinalli 50 to 70, according to your local guidelines. Once you reach 300 milligrams per deciliter, you convert the fluid from normal saline and use 5 dextrose half normal saline. And in potassium, you always give potassium if it's the levels are less than 3.3, so you give 40 milliequivalents. If it's more than 5, you don't need to give anything. If it's between 3.3 and 5.5, 5 milliequivalents per liter, you give potassium to maintain at a level between 4 and 5 milliequivalents. Complications of HHS: cerebral edema. It's rare in adults, common in children, and if it does happen, of course you will see that there will be changes in the Glasgow Coma Scale, or total mental status, coma or stupor. Usually the treatment is mannitol, but it's a very hard condition to treat. Pulmonary edema is another condition that can happen from, of course, the fluids that are being given at high rates, so that can happen, and in this condition you might want to consult cardiology and consider giving furosemide. Again, you always monitor the Glasgow Coma Scale. If there is any change in mental status, you send for a CT or MRI, and you consider prophylactic anticoagulation and prophylactic antibiotics. The reason for giving anticoagulants is because, as we said, HHS is a condition with hyperosmolarity and highly thrombotic condition, so you want to give enoxaparin or aspirin to prevent strokes and cerebrovascular accidents. And you also consider prophylactic antibiotics because that could be the precipitant condition, especially in patients where you don't know what exactly is causing the stress and the HHS. You want to give prophylactic antibiotics. Now, again, after the 6-hour period, it's more likely that you're going to refer the patient to the ICU, so they continue the monitoring for 24 hours until 3 days, for example, until the electrolytes are all balanced and the patient's condition is better. Then you start step down care. You start decreasing the rates of insulin, decreasing the rates of fluid. You start giving long-acting insulin subcutaneously, and then, for example, patients who develop hypothermia, hypotension, tachycardia, and bradycardia, or hypernatremia more than 160, or osmolality more than 360, these are all indicators of poor prognosis. And the risk of readmission increases the younger the patient is, if he has depression and is using antidepressants, or the HbA1c is more than 10.6. Thank you for listening. This was a long lecture, and I hope it was useful. I tried to summarize as much as I can. I tried to use many references like Tintinalli, Davidson, Harrison, and I hope it was useful. Thank you.